Hello, this is Fernando Gómez Sancha from the ICUA at Clínica Centro in Madrid, Spain, commenting on this case, an En Bloc HoLEP after failed TURP. TURP is considered by many the gold standard for surgical treatment of BPH, but in my opinion, it's hardly ever complete, in the sense that after TURP, most patients will still have adenomatous tissue that can grow with time and lead to reoperation. In this case, as you have seen, there was a synechia in the prostatic urethra, and the patient was still obstructed and bothered by his symptoms. He developed a bladder stone that was very easily removed with after fragmenting it with holmium laser and evacuated from the bladder. And in this case, it's very interesting that holmium laser is a good option for retreatment, due to the fact that the plane of dissection between the adenoma and the surgical capsule is easy to develop, even when there has been a previous TURP. So that's the last part of the stone coming out by gravity, emptying the bladder. And as you can see, that's the synechia, that's the verumontanum, the two lateral lobes, and finally the sphincter. What I'm going to describe in this video is an en bloc technique that I am loving so much lately, because it is extremely elegant, and I think it protects the sphincter much better than the classic HoLEP techniques. Some people think that en bloc enucleation is going to carry a higher risk of incontinence, but I think it's the opposite. I think that if you start anteriorly like this, developing an incision between the sphincter and the apex anteriorly like that, this is going to be very, very good for protecting the sphincter. You can see that the sphincter limit is well marked, and I like to mark this white line all around the apex, and my objective is going to be to try to release the apex from the sphincter as soon as possible. As you can see, it's important to do a single white line and then respect the limit. You see, this initial work creates a groove in the prostate where the resectoscope is going to fall naturally. And then, of course, it's a visual landmark that you can set in your operation to know where is the limit of the sphincter, but also it's a mechanical landmark in the sense that when you're working at the apex, the tip of the scope is naturally going to get into that groove, protecting the sphincter. You see, there has been a groove that goes all around the apex, following this white line and demarcating the lower limit of our operation. I like to combine the mechanical dissection moves. You see, the tip of the scope allows us to do this, to dissect the plane mechanically, and many times it's very useful to make sure that we are in the proper plane when it is not obvious from the endoscopic view, especially after using some energy. So I would say that I don't agree with this idea of doing a no-touch technique for enucleation, because I think mechanical movements can be very, very good for discovering where the plane is and to help in the dissection of the proper plane. As you can see, I have also cut the crista urethralis to develop the posterior aspect of the plane between the adenoma and the prostate. So you see how fast at the beginning of the operation, the landmarks are set. After this point, I like to have the fiber more at 12 o'clock, as it is easier to work towards the anterior part of the prostate with the fiber in this position at 12 o'clock. So as you can see, I'm very, very careful trying to preserve what is above in the white line. So you have to very carefully dissect the adenoma from the gland. You see that the holmium energy is opening up the plane and at the same time is providing with hemostasis. So it fulfills this double purpose of performing hemostasis and opening the plane. But also we have to be very, very cautious to respect everything that is anterior, which is still the sphincter. Here we are reaching the landmark at 12 o'clock, the place where we marked the limits of the sphincter at 12 o'clock. And you can see that even when the patient has had a TURP, the dissection of this plane is quite straightforward because energy never reached there. That's crossing over a little bit to the other side, to the right side of the patient. But here what I'm doing is to do an initial liberation of the apex. I'm trying to start the operation by liberating the apex completely from the sphincter, because this will avoid pulling the sphincter, and you'll see that once the apex is totally released from the surgical capsule, the rest of the operation is really, really simple. And I think this approach has some advantages over classical approaches where the incisions on the prostate were made to remove, let's say, lobe by lobe the prostatic adenoma. Here you see that now this side, let's say, of the apex of the prostate has been released, and I'm working to dissect this plane. One of the nice things of doing an en bloc operation is that the space where we are working is quite limited, so the flow of water is going to flush very efficiently any amount of blood that goes into this space, which means that we will have good visibility all along the operation. Okay, that's one side. Now we go to the other side. This is where we marked the white line and the lower plane. Of course, if there is any vessel that bleeds during the operation, it's better to tackle it while you're doing the operation and not wait to the end to do hemostasis. As here you can see the white line and how carefully I'm climbing up, trying to respect what is anterior, trying to respect the sphincter above the fiber at this exact moment. So again, the idea is to climb up. Here I'm using a little bit of mechanical dissection. Sometimes mechanical dissection liberates this part of the prostate easier than energy. This is something that comes with experience. And as I said, there's no sin in using some mechanical dissection, and many times it's extremely helpful. Here you see that's the apical part, and again we are respecting this white line and respecting what is anterior to that. But then it's important to follow the plane all the way up, because we want to make sure that we're not leaving tissue anteriorly after we release the sphincter. So that's the idea. Climbing up, trying to be very conscious of where we are in relation to the sphincter and in relation to the white line. There were some adenomatous nodules at the apex in this point that I had to remove, but you see that we have been operating for 10 minutes, including the removal of the stone, and almost the apical part is completely freed. I will be happy when I'm able to cross, let's say, from one side to the other side at 12 o'clock and I see that the apex is completely free, and the sphincter has no longer attachments to the apical part of the prostate. So there we are. And as you can see, another advantage of this en bloc approach is that once the apex has been released, following the plane, following the line, is very easy, because you have a very, very long line of attack, very uniform, and it is, in my opinion, much easier to stay in the right plane when you have this circumferential line of attack and this amazing visibility. When you remove one lobe and then do hemostasis and then move on to remove another lobe, there is some blood in the cavity that you are starting to generate. Whereas here, as you can see, we have very nice visibility, and also you can realize that the pausing time is reduced. With this good visibility and with this clear line of attack, you can almost work continuously with your laser to develop the plane, so the stopping time in the operation is greatly reduced, which means that we will be able to complete this operation in a very, very short time, which I think is another advantage of this en bloc enucleation. It takes, I guess, less time to do a prostatectomy in this kind of operation. As you see, the sphincter is now totally free and released from the apex, so even when we have to do big movements around the adenoma, even in big adenomas, the sphincter is going to follow with the scope, because there's a lot of mobility of the sphincter, and it will not be stretched. It will not be stretched. There you see that the work is continuing very fast. The plane is being developed. I tried to keep the fiber pointing a little bit more towards the side of the adenoma, because this allows to have a mild, let's say, coagulation effect on the other side, and it reduces the possibility of perforation in the prostate. If there is some, let's say, deepening in the capsule, it's very easy to correct the trajectory. But as you can see, I'm trying to circumferentially detach the adenoma as I work. Try to make it a uniform line, and there we will try to find the access to the bladder neck. It's important to remember that the contour of the prostate is more or less spherical, which means that once we have climbed over the top part of the adenoma, the bladder neck is going to be a little bit lower down. So, and the same way, when we are working here in the lower part of the prostate, in the posterior aspect, we cannot continue cutting straight, because this would take us out of the prostate. We have to know that we have to cut a little bit further up. Here, we were lucky enough to enter the bladder at 6 o'clock. Usually I would try to enter the bladder a little bit further up, you see, as I prefer to enter anteriorly, but in this case, the plane led us directly to enter the bladder at 6 o'clock. That's the anterior part. You see there's still some attachments that I'm trying to release. If there's any bleeder, of course, it needs to be controlled, because if you do a good progressive hemostasis as you work with the laser, you will not need to do much hemostasis at the end when you have to switch to morcellation. So it is really saving time to stop a little bit and don't get carried away with, let's say, advancing with the procedure. No? Here, that's anterior tissue, and that's the access to the bladder neck. You can see that the access to the bladder neck lays a little bit low. So once you have climbed the higher aspect of the adenoma, you have to lower the aim of your laser as you approach the bladder neck. And as you can see, it's a matter of continuing the release and following the principles. The principles would be to stay in the right plane and to do good hemostasis as you go. Point the fiber towards the adenoma a little bit more than towards the capsule. So if you cut something, it's better to cut into the adenoma than to cut into the capsule. And keep a good visibility so you can continue working at a nice pace. You see, it's been 16 minutes of operation now, and most of the prostate is detached from the attachment to the surgical capsule, and we are approaching the bladder neck circumferentially. That's near the bladder neck, cutting the mucosa. Of course, there are some nasty vessels around here that sometimes need a little bit of attention. For this operation, I was using a 50-watt Auriga XL holmium laser from Boston Scientific, which is the one we use in Sofia, Bulgaria, when we do holmium laser. And as you can see, even working at relatively low power, I think it's 34 watts or something like that, we can have very nice hemostasis and very nice detachment of the adenoma. Here I'm checking on the UOs. Usually the initial inspection will tell you where the UOs are in relation to the bladder neck, and they will help devising a strategy to protect them. That's again bladder neck being cut, and there is some vessel that we need to localize. When you see this kind of bleeding, it's important to realize that there is a vessel, let's say, pouring blood against your lens, but it's in no way a severe bleeding. Usually you just have to be patient to coagulate. And as you can see now, most of the adenoma is mobile. There's still some attachment, small vessel that needs coagulation. But I think now the adenoma has been released circumferentially, and now it's being pushed into the bladder. You see 17 minutes and 45 seconds took to remove this adenoma. It's not a large prostate, but you can see the quality of the preservation of the sphincter. Basically, we marked our white line, and there's no mucosal damage below the white line, which I think is very important for postoperative continence. So patients will have earlier continence, I think, if the totality of the mucosa of the sphincter is preserved. You know that the mucosal seal is very important for continence, and I suspect that the high rates of stress urinary incontinence found in different groups' experiences with holmium laser are due to the fact that when they dissect the apex, they don't, let's say, do any effort to preserve this mucosa, and many times when they're finishing the 12 o'clock liberation, there's only a strip of mucosa remaining in the sphincter, but the rest of the sphincter has been denudated completely. So that's why I see a merit in preserving this mucosa. So this is the final hemostasis before switching to morcellation of the tissue. If you are more careful with hemostasis as you go, I was working, let's say, relatively fast in this case. You have to find a good balance between, let's say, working fast and progressing fast and having a good hemostasis. In this case, it was not too bad. Of course, once the adenoma is removed from this cavity, there is no longer such beautiful visibility as when we had this very, very small space to irrigate. Here there is more chaotic flow, and if there is some bleeding, the quality of the visibility will be a little bit less. But again, that's the beautiful preserved sphincter, and I think in no time we're going to change the instrument to proceed to morcellate. It's again how you have to review and avoid major bleeding. There's a little bit of oozing of blood that you cannot, let's say, you cannot stop sometimes, but the major bleeders have to be stopped, otherwise visibility could be bad during morcellation. That's a capsular bleeder that needs some attention. In my opinion, the 100 watt holmium laser is probably better for coagulating big vessels, but usually there's not so much problem with this lower power laser to coagulate vessels, and if there is, we do a fast switch to a resectoscope to coagulate the pumper, the bleeding point, and then go back to the laser again. This is the change. I'm changing the laser cystoscope for a nephroscope or morsescope that will help me introduce the blades, and my nurse is helping me to do the change of instrument. There you go. We don't want to decompress the bladder and to have more bleeding starting, so we have a reasonable visibility. And I'm going to input the morcellation blades. There it is. It's a Piranha system with a single use fast blades that provide a very fast morcellation. It's been 22 minutes now from the beginning of the operation, and we start the morcellation of the remaining tissue that was left after TURP and probably grew over time and produced lower urinary tract symptoms again. I think TURP is overrated. I think endoscopic enucleation of the prostate is a much better procedure to provide a long-term result to patients who want to get rid of their urinary symptoms due to BPH. So as you can see, this morcellator is very safe. I like to see the wolf logo on the blade, which means that you have to push the blade quite inside the bladder and then come close to the bladder neck. If you look at the lower aspect of the image, you can see that I can see a little bit of bladder neck in both sides. So I know that I am with my blade right above the trigon, and I keep it very static, so there is no danger to the bladder. There it is, the morcellation finished, and there's still a little bit of oozing, but the catheter will stop that, and the procedure has finished. Thank you very much for your attention.